Hello everybody, my name is Ahmed Serwer. I am a third year medical student from the University of Suleimania of Kurdistan, which you probably has never heard of. So let's try to change that. In this short video, we're going to be talking about adrenergic receptor, or more commonly known as sympathetic receptor, or as most people call them, alpha and beta receptor. So what are they? We're going to be talking about them in a second, but before doing that, let's be refreshing our memories about the nervous system. So what is the nervous system? Well, basically, nervous system is every information you are getting from the environment is going to be coming to the nervous system, interpreted inside the nervous system, and even responded to by the nervous system. So the information that you are getting from our environment, the visions we are seeing, the words we are hearing, or the smell, is coming to our nervous system as sensory information. Then inside our brain going to be interpreted, and then we're going to have some sort of response for it, which can be movement, talking, or anything, which is called the motor aspect. And nervous system, in order to do this beautiful thing for us, is divided into two different parts by the names of central nervous system, or CNS, and the peripheral nervous system, or simply PNS. So what are they composed of? Well, the central nervous system is composed of two things. It is composed of the brain and the spinal cord. And the peripheral nervous system is composed of every aspect of the nervous system that is not the central nervous system, which can be classified as the 12 pair of the cranial nerves, the 31 pairs of the peripheral nerves, and their associated ganglia. But as a matter of function-wise for us, it can be classified into two portions by the names of autonomic nervous system and the somatic nervous system, in which these two portions is going to be controlling, doing all the things that the peripheral nervous system is doing for us, which is basically, what is the difference between them? In simple words, somatic nervous system is controlling our skeletal muscles, our movement. What do we do? What do we not do? That's the only function of the somatic nervous system. And somatic nervous system, it is composed of one neuron, meaning that it does not have a ganglia. It is just composed of one neuron going from the basically the nervous system centers to our skeletal muscles and telling us to do something. And as we all know, this portion of the somatic nervous system, it is composed of one neuron. There is no ganglia. And since it is our skeletal muscle, our hands and our legs and our speaking, basically, it is voluntary, meaning that we have control over it. On the other hand, the autonomic nervous system, it is composed of two neurons. It has a ganglia. We have preganglionic neuron and postganglionic neuron, in which it is controlling everything else, from our hearts to our smooth muscles to our glands to everything. And it is involuntary, meaning you are not telling your heart yourself to increase in beating, but because as we all know, heart has excitability, it is beating on its own. But the nervous system can increase or decrease its beating, but you are not controlling it. It's not in your hand. It is involuntary. So it is composed of two neurons. It is involuntary, and it has ganglia. And the autonomic nervous system can be classified into two groups, in which they are called sympathetic nervous system and parasympathetic nervous system. Both of them are composed of two neurons. Both of them are involuntarily. So what is the difference between them? So we can say the whole point of this topic is identifying that the autonomic nervous system can be classified into two groups, which is called the sympathetic nervous system and the parasympathetic nervous system. So what are they doing? What's the difference between these two? Well, basically, sympathetic nervous system, you can simply think of it as everything that's happening to your body when you are seeing a big dog, or if you are very brave, when you are seeing a lion. In which, if you think about it and have time for it, you would realize that your heart gonna be beating faster. You would have increased heart rate, and you're gonna have increased respiratory rate as well, because you wanna be breathing faster, don't you? And you're gonna have more blood going toward your skeletal muscles. So blood flow toward the skeletal muscles will increase because you wanna have ability to run. But on the other hand, your digestive system will have decreased blood flow because you do not need to digest anything, do you? You want to run, you don't need to eat. So digestive system gonna have decreased blood flow. And your pupil gonna be dilated, or what is called in medicine as mydrias, because you want to have a better view of your peripheral vision. On the other hand, parasympathetic nervous system is kind of the exact opposite of it. It's kind of the exact opposite, not the exact opposite, because in detailation, there is some difference between them. But parasympathetic nervous system is associated with relax and digest. So when the parasympathetic nervous system is being activated, which is after we have successfully run from the lion or the big dog and you are kind of getting an idea about it, getting a breeze, we're going to have decreased heart rate, basically. We're going to have decreased heart rate. We're going to have a decrease in our respiratory rate, which is going to be called vagal tone. So parasympathetic nervous system is also called the vagal nervous system in some sources. And then we're going to have decrease blood flow to our skeletal muscles because we no longer need to run, and increase blood flow to our digestive system because now we can eat, and we're going to have meiosis, which is pupil constriction, because now we need to see the peripheral vision anymore. So in this video, we are focusing on the sympathetic nervous system receptors. But in order to understand receptors, of course, we need to understand ligands, because receptors themselves are nothing. For receptors to work, we need the ligands. So what are the ligands of the sympathetic nervous system? Well, the sympathetic nervous system have basically got two ligands in our body endogenously, meaning they are already present. They are called the sympathetic nervous system ligands. What are these ligands? These ligands can be one of two things. They can be either epinephrine or they can be norepinephrine, or also called adrenaline and noradrenaline. So what is the difference between these two? Well, basically, both of these can be present as both hormones and neurotransmitters. But norepinephrine, which starts with an N, is mostly a neurotransmitter, more often considered to be a neurotransmitter and less often considered to be a hormone. On the other hand, epinephrine is mostly considered to be a hormone and less often considered to be a neurotransmitter. So, where are they produced as neurotransmitter? Basically inside neurons, usually inside the brain and the spinal cord. What about as hormone? As hormones, they would be produced inside the adrenal medulla of our adrenal glands. Which part of the adrenal medulla? Well, the chromaffin cells are associated with the production of both epinephrine and norepinephrine. But when we are talking about their neurotransmitter portion, we are considering about which comes first. This is not like the egg and the chicken scenario, which nobody knows what happened. We know what happened. Basically, epinephrine is produced from norepinephrine, meaning that as a neurotransmitter, norepinephrine will be produced first, then it will be producing the epinephrine. So where does norepinephrine come from? Well, norepinephrine comes from the big guy dopamine. So what does dopamine come from? Well, dopamine comes from an amino acid that's called tyrosine. So let's come to this paragraph and explain how this is happening. Sorry about my drawing because I'm terrible at it. Talk about how does tyrosine is forming norepinephrine and epinephrine. Well, basically, first thing first, we have tyrosine itself, which is an amino acid. Which type of amino acid it is, I honestly forgot, which we studied this in the first year of medical school. But for now, I don't know which type of amino acid it is. But the idea is tyrosine is an amino acid. It's going to be coming into the neuron, which is basically the presynaptic neuron like this. And it's going to be making way for itself. Sorry about the markers of writing. It's going to be making way for itself and enters the cell. Inside the presynaptic neuron, what will happen? Tyrosine is going to be converted by an enzyme that's called tyrosine hydroxylase into what is called DOPA. And then DOPA is going to be converted by another enzyme by the name of DOPA decarboxylase into dopamine, which is DOPA decarboxylase converts into dopamine. And dopamine, after forming, it is going to be stored inside vesicles. So we're going to have big vesicles in here, which is going to be containing dopamine. And by an enzyme, it's going to be converted into the norepinephrine. So what is this enzyme called? It is called dopamine beta hydroxylase. It's going to be converting into the formation of norepinephrine. Then later on, norepinephrine can be converted into epinephrine by an enzyme that is very low yield information. But if you want to know, this by the names of phenylethylamine and methyltransferase, which is called PNMT. I don't even know how I remember this name. I basically Googled it before the video, I swear, because this enzyme is definitely not important, but it's going to be forming epinephrine. And later on, either the vesicle will be containing dopamine, or it's going to be containing norepinephrine or epinephrine. For the sympathetic nervous system is going to be either containing norepinephrine or it's going to be containing epinephrine. And whenever it is needed, it will be secreted into the synaptic. So let's assume we have a vesicle that is full of norepinephrine, and then we need it to be secreted into the synaptic cleft. So what will happen? So basically, it will undergo exocytosis. Basically, this part is going to be eliminated like this, and then the neurotransmitter, which is norepinephrine, will be coming into the synaptic cleft. And from here, this synaptic cleft, which is filled with norepinephrine, the norepinephrine can go through a number of ways. For example, in here we have what is called an reuptake receptor, in which it is going to be reuptaking norepinephrine back into the neuron, which is one way. Or it can be basically affecting the alpha-2 receptor, which are located around here, which is the second way, in which alpha-2 receptor will be activated, and in which we're going to be talking about alpha-2 receptor. But the activation of alpha-2 receptor in the presynaptic neuron will simply cause a decrease in the release of norepinephrine, which is quite interesting. Or maybe the norepinephrine going to be affecting a receptor that is located on the postsynaptic neuron, which can be alpha receptors or beta receptor, and it is mediating various functions that is mediated by them. But to be honest, norepinephrine is mostly affecting alpha-1 receptor by the way. But anyways, or it can be destroyed, which is this one is the third way. It can also be destroyed by two enzymes, basically eliminated by ketocholomethyltransferase or monoamine oxidase, in which this is the fourth way. There can be in theoretical a fifth way as well, in which the norepinephrine gonna be diffusing outside into the circulation. So that one is very rare because neurotransmitters are usually short duration. But if it was have been a hormone, it will be immediately secreted into the bloodstream from the chromatin cells. So basically, that's the function of norepinephrine. So now let's come to the beauty of our topics. What are adrenergic receptors? To talk about adrenergic receptor, we need to talk about a special type of receptor, which is G protein coupled receptor. Why? Because adrenergic receptors are a type of G protein coupled receptor. So what is G protein coupled receptor? Well, G protein coupled receptor is a cell surface receptor, meaning that it is not an intracellular receptor. As we all know, receptor can be classified into two groups. We have cell surface receptor, which is located on the surface of the cell, and intracellular receptor, which are located within the cell cytoplasm or the cell's nucleus. So G protein receptor is belonging to the cell surface part. And it is a special type of receptor. Why? Because it is coupled with G protein. So it is not like receptor on the cell surface that are controlling enzymes or ligand-gated ion channels. This is controlling G protein. When the particular ligand that is needed for the G protein coupled receptor is binding to the receptor, there is going to be some sort of conformational change happening inside the receptor that will lead to the activation of this G protein. How the G proteins will be activated? Well, simply a GDP will become a GTP. So basically, this formation of GTP will activate G protein coupled receptor. And when the receptor is being activated, it will either be regulating an ion channel or regulating an enzymatic function. What ion channel is it regulating? Which is ion channel regulation is, to be honest, in G protein coupled receptor is quite less common than the controlling of enzymes. But ion channel that is controlled by this receptor can either be potassium channels, most commonly, or calcium channels. Of course, there may be some other channels controlled by them, but mostly it is potassium channel and calcium channels. What about the enzymatic function? Well, the enzymatic function can be one of two important enzymes, which can be phospholipase CC, or it can be adenylate cyclase phase C and adenylate cyclase, in which these enzymes gonna have different functions. So what is the difference between them? And what will happen? Well, basically, the idea is we have different types of G protein coupled receptor. For example, we have GQ receptor and G11 receptor, in which they are very similar in their function to each other. That's why some sources still simply call them as GQ11, in which activation of GQ11 receptor will lead to activation of phospholipase C enzyme, which phospholipase C enzyme later on lead to the conversion of PIP2 into IPC and DAG. And then the IPC has an important function. As we all know, inside the cell we have intracellular calcium source, in which they are gated by a channel, and the channel is responding to the ligand IPC. So this IPC is going to be binding to the intracellular calcium channels, and what will happen? It will lead to an increase in the concentration of intracellular calcium. So that is GQ11. But on the other hand, we also have GS and GI, G protein coupled receptor, in which GS gonna be activating the enzyme adenylate cyclase, which will have a positive effect on it. And then activation of adenylate cyclase will lead to an increase in the concentration of CAMP. And the GI or inhibitory will have the exact opposite. It will lead to inhibition of adenylate cyclase, a decrease in the CAMP. So why do I talk about all of this? Well, basically the idea is adrenergic receptor can be belonging to different types of the G protein coupled receptor. So let's come to their classification. Well, as we all know, adrenergic receptor can be classified into two groups, in which they can be called either alpha receptors or they can be called beta receptor, which is the whole idea of our topic. Alpha receptor can be classified into two groups as well, which are called alpha 1 receptors and alpha 2 receptors. And beta receptor can also be classified into three groups, not even two. They are called beta 1 receptors, beta 2 receptors, and beta 3 receptors. So all of the beta receptor are GS, G protein coupled receptor, meaning that activation of any of these will lead to activation of adenylate cyclase, which will lead to an increase in the concentration of CAMP, cyclic adenosine monophosphate. So they are GS receptors, all of them. But alpha 1 receptor, which can also be subcategorized into three groups, commonly, which is alpha 1A, alpha 1A, alpha 1B, and alpha 1D, because for some reason they were hungry and we eat C. It can be classified into 3 groups, and alpha 2 is also classified into 3 more groups, which is alpha 2A, alpha 2B, and alpha 2C. These are different. What do I mean? Basically, alpha 1 can be classified as either GQ or G11, but like I said, they are very similar in action. So alpha 1 receptor is considered to be a GQ11 receptor, and alpha 2, on the other hand, is considered to be a GI receptor, meaning that activation of alpha 2 will have an inhibitory effect. So let's come to the exact mechanism in which they are functioning. Well, basically, alpha 1 receptors are mostly located inside the peripheral vasculation. So the most common site of action is the peripheral vasculation, which is every blood vessel outside of the central system, away from the heart and the brain, is controlled by alpha 1 receptor. And activation of alpha 1 receptor will cause an increase in the intracellular calcium, which will lead to a contraction of the smooth muscle of the blood vessel. So it will lead to increase in vasoconstriction. So it will cause an increase in the vasoconstriction, and increase in the vasoconstriction will of course cause, sorry about that, an increase in the total peripheral resistance, and an increase in the total peripheral resistance will cause an increase in the blood pressure. But alpha 1 can also be found inside the eye, in which activation of alpha 1 receptor inside the eye will lead to pupil dilation, which is called mydriasis. And also, it is causing an increase in the closure of the internal sphincter of the bladder. So it has these important functions. What about alpha 2? Alpha 2 is an inhibitory receptor because it is a GI, and alpha 2 can be mostly found inside the presynaptic neurons. And activation of alpha 2 receptor will have an inhibitory, meaning that it will cause a decrease in the release of norepinephrine. But high doses of alpha 2 activation will even cause a decrease in acetylcholine and insulin. So it is basically having an inhibitory effect, and it is having a negative feedback mechanism. So it is causing a decrease in the norepinephrine, in acetylcholine, and in insulin. Now let's come to the beta receptors. So beta 1 is mostly located inside the heart, in which activation of beta 1 receptor will obviously have a stimulatory effect, in which it is causing a positive inotropic and positive chronotropic effect, in which positive inotropic effect means an increase in the cardiac contractility. Cardiac contractility will increase, and it will cause an increase in the heart rate by the positive chronotropic effect. These two, of course, will increase cardiac output, which will once again increase blood pressure. But also beta 1 receptor will obviously lead to an increase in the release of renin in the kidney glomeruli. So an increase in the renin in the kidney glomeruli will lead to an activation or an increase in the renin angiotensin aldosterone system, leading to basically increasing the retention of salt and water, once again an increase in the blood pressure. Beta 1 can also cause lipolysis to a lesser degree inside the adipose tissue, just for the sake of doing it. But lipolysis inside the adipose tissue is mostly controlled by beta 3 receptor, in which their sole purpose of life is doing lipolysis. So last but not least is beta 2 receptors. So what does beta 2 receptors do? Well, basically, beta 2 receptors, which there is no place left in the board, but let's come here. Beta 2 receptors are mostly located in the bronchial smooth muscle, meaning that they are controlling the bronchi. So activation of beta 2 receptor will lead to the bronchodilation. It will cause vasodilation, in which it is causing the vasodilation of the blood that is going to the skeletal muscles. But vasodilation will cause a minor decrease in the blood pressure, in which can be good or can be bad according to the scenario. It is also having other important functions. For example, beta 2 receptor is causing an increase in the release of glucagon. So this is causing this. It is causing an increase in the release of glucagon release. It is also causing compensatory glycogenolysis and glucose release in response to decreasing the blood glucose level. So it is causing glycogenolysis as well. And last but not least, the beta 2 receptors are responsible for causing uterine smooth muscle relaxation, meaning that they are preventing labor, as simple as that. That's why beta 2 agonists can sometimes be used as tocolytic agent, which is preventing premature labors. So that's all about it we're going to talk about in the board. Now we're going to go to some slides that we have prepared as a quick revision of this topic. Hello everybody once again. So let's come to the little material we prepared about this topic. As a quick review, we're going to be using this material. Basically, like we said, we have the nervous system, in which it can be classified into two groups: central nervous system and the peripheral nervous system. Like we mentioned, the central nervous system can be classified into the brain and the spinal cord. So, as simple as that. And the peripheral nervous system is everything else. Basically, it is classified into the autonomic nervous system and the somatic nervous system. And the autonomic nervous system can also be classified into sympathetic and parasympathetic. So, let's come to the formation of noradrenaline or norepinephrine. Basically, as a neurotransmitter. This is talking about noradrenaline formation, production as a neurotransmitter, not as a hormone, because it can be a completely different story. Basically, we have tyrosine amino acid going to be entering the presynaptic neuron. By tyrosine hydroxylase, it's going to be converted to dopa. Then by dopa decarboxylase, it will become dopamine. Dopamine will enter vesicle. By dopamine beta hydroxylase, it will become norepinephrine. If it wants to become epinephrine, then norepinephrine can undergo basically phenylethanol and methyltransferase, which is PNMT. Like I said, this is low real. No need to know this enzyme. It will become epinephrine. Later on, it can be secreted whether norepinephrine or epinephrine can be secreted into the synaptic cleft as it is needed. From there, it can either be reuptaken by the neuronal reuptake receptor, or it can be affecting alpha-2 receptor and cause a decrease in the release of norepinephrine, or it can be affecting postsynaptic neuron, which can be alpha or beta receptor, or it can be diffusing into the blood, which is very rarely occurring, or metabolized by catechol or methyltransferase and monoamine oxidase. This neuronal reuptake receptor can be blocked by cocaine, which is a completely different topic, which is causing an increase in the sympathetic nervous system. Hopefully, we're going to be able to talk about these drugs in the future. So, basically, let's come to the action of the G protein coupled receptor, because we said adrenergic receptors are a type of G protein coupled receptors. So, G protein coupled receptors is a receptor that is coupled with G protein, in which they are also called 7 transmembrane domain receptors, because their transmembrane portion have 7 domains. This is just a name that you can know, but it's not necessary. Basically, the idea is to know this receptor is coupled with G protein. So when a ligand binds to it, like we mentioned, the G protein will be activated because the GDP will become a GTP. Then it's going to be controlling either ion channels such as potassium ion channels or calcium ion channels, or enzymes such as phospholipase C, basically, or it could be controlling phospholipase C or adenylate cyclase. So now let's come to the adrenergic receptors. Once again, it can be classified into alpha receptors and beta receptors, in which beta can be beta 1, beta 2, and beta 3. Keep it in mind, this is GS, meaning it is activation will activate adenylate cyclase, will lead to an increase in the CAMP. And alpha receptor can be classified into alpha 1 and alpha 2, in which alpha 1 receptor can be classified into alpha 1A, alpha 1B, and alpha 1C, in which it is GQ11. Keep that in mind, because its activation will activate phospholipase C, which will convert PIP2 into basically IPC and DAG. And then the IP3 will cause an increase in the intracellular calcium concentration. And alpha-2 receptors can be classified into alpha-2A, alpha-2B, alpha-2C, in which it is GI, meaning that their activation will have an inhibitory effect on adenylate cyclase. Adenylate cyclase will be inhibited. As a result, we're going to have a decrease in the CAMP levels. So let's come to the main function of the adrenergic receptors. So adrenergic receptors can be classified into these four main receptors. Of course, we also have beta 3, in which beta 3 is affecting adipose tissue, leading to lipolysis. But these receptors have many different functions. For example, alpha 1 receptor is mostly located in the peripheral vasculature. It is causing vasoconstriction in that area, and the vasoconstriction will increase peripheral resistance, will increase blood pressure. It may cause mydriasis or papillary dilation, or increase in the closure of the internal sphincter of the bladder to a lesser degree in compared to the vasoconstriction, of course. Alpha-2 receptor is mostly located in the presynaptic neuron, in which their activation will have an inhibitory effect. That's why they are called to have a negative feedback mechanism, basically. It is causing an inhibition of the norepinephrine release, and at basically high stimulation to cause the inhibition of the acetylcholine release and inhibition of the insulin release. Beta-1 receptors are mostly located inside the heart, in which they may cause an increase in the heart rate, causing tachycardia or positive chronotropic effect. They may cause an increase in the myocardial contractility, positive inotropic effect. They may, to a lesser degree, cause lipolysis, or they may cause an increase in the release of renin and activation of the RAA system, which is renin-angiotensin-aldosterone system, causing salt and water retention, aka leading to increase in the blood pressure. Beta-2 receptors are mostly located in the bronchial smooth muscle, in which their activation will cause bronchodilation, but they may also cause vasodilation in the skeletal musculature, leading to a slight decrease in the peripheral resistance and a decrease in the blood pressure as well. And they may also cause increased muscle and liver glycogenolysis, may cause an increase in the release of glucagon, and relax uterine smooth muscle. So that's all we talked about. Let's get back to the board for our outro. So this is the end of our video, but we want to talk about a couple of things. First of all, so basically we are really new to this, as you can see. So please tell us in the comment section, what do you like us to keep? What do you like us to improve? What do you like us to drop and to change? Basically every opinion, suggestion, ideas, criticism, we're going to be thinking about everything, every one of them, and we're going to put them into consideration so we can try to make ourselves better. The second thing is, please tell us in the comment section, what do you want us to talk about next from every field of medicine: anatomy, physiology, pathology, you name it. If you know about it, we're going to be talking about it. And if we don't, we're going to try our best to learn it and then talk about it. And last but not least, we're going to be creating a Telegram channel in which we're going to put the materials that I just talked about in the iPad into there as PDF, and just jiba jabrani add there as well, so you can benefit from it. So you can join that channel if you like. We're going to put it in the description as well as in the comment section. If you could, please drop us a like, a comment, and subscribe. And last but not least, thank you very much for watching our video. Hope you enjoyed it and it was beneficial. This is a fight between you and you guys. Keep studying, keep working hard. So hopefully your future, you're going to be much smarter than you are right now. And have a great time, and goodbye.